to enlighten us on chest X-rays. As we all know, it's a very old friend for us, the chest X-rays in diagnosing as well as treating various conditions. I would like to welcome Sir, who have kindly accepted our invitation to join us today. I would like to welcome my convener, Dr. Nisha, my good friend, Dr. Ranjit, who have joined us today on this platform to attend this CME program for house surgeons. Next, I would like to welcome all the house surgeons who have joined us today to get enlightened on chest X-rays. And as we all know, we come across a lot of radiology investigations in our day-to-day practice, and sir will definitely enlighten you on this topic. Once again, welcome all of you to this program. Over to you, to Dr. Nisha, for the introduction of our speaker. Thank you.
Thank you, sir. So, over to our speaker. Speaker for today is Dr. Thangavelu, sir. Sir, MD, DCH, DNB, and MRCP in pediatrics. Is a director of pediatrics, Mehta Hospitals, Chennai. So, sir is an astute clinician, academician, and sir's lessons and sir's sessions are always attended with. There is a huge audience for sir's sessions and all. So today sir will be detailing on the topic interpretation of chest X-rays in pediatrics. We know that chest X-ray is a leading investigation which we order for any patient presenting with respiratory symptoms and all, the casualty in the OPD and all. So over to sir.
Sorry, am I visible and audible now, Dr. Johnny and Dr. Isha?
Yes, sir.
Yes, sir.
Can you make it full screen?
Yeah,
Yes, sir.
So I just have some
Thank you.
152 slides in a given time of 60 minutes, but it's all pictures only, very little text. But anyhow, if time permits, you can give me another 15 minutes time. Thank you very much. Ignite is a very powerful word because of the ignited minds written by our great teacher, president, and scientist Abdul Kalam. I'd like to thank all our friends, Dr. Riaz Gopi Mogan, Binu Kutan, Johnny, Nishan, all the viewers who indirectly made me to prepare this talk. Thank you so much. I'll just talk. So chest X-ray is something like a neglected grandpa. It was discovered in 1895. So how many years? Almost 110 years, not 130 years old. Neglected grandpa. So many investigations come after that, no? USG, CT, PET CT, MRA, MRA, MRB, MR, nothing. Everything has come, all new investigation come. But nothing has so far replaced X-ray. Just still that 25 or 130 years old grandpa is still very busily walking around in the hospital. You can't remove X-ray from our hospitals. Who is the owner of the X-ray? Earlier, radiologists were the owners. Now, probably the clinicians, pediatricians, or house surgeons, all they are the owners because radiologists are very busy with doing a lot of other advanced investigations. So it is a time for us to take over the X-ray. I did my house surgery in 1974, almost maybe 51 years ago. I still remember my teachers who very, very fervently taught X-rays because that is the only investigation available. None of the investigation available when I did my house surgery. So we were focusing only on X-ray. Why this so much precious is, it's cost only 500 rupees. Get the result within 5 minutes. So let us adopt this chest X-ray because that is the X-ray will open the diagnosis of many things, mass, cardiac disease, empyema, pneumothorax. General rule in ICH Chennai is when whoever orders X-ray, they have to see the X-ray within 5 minutes if it is in ER or PICU, or 30 minutes if it is in the ward. And we have to spend at least 2 to 3 minutes in the X-ray viewer, 2 to 3 minutes. Just in front of the tube light or few seconds may not be good enough to pick up all the findings. There's a 2-year-old child brought to emergency room. Child is gasping, shock, hypotension, desaturation. History is around 7 o'clock when all the children are playing around, a big speaker fell over the child. It's an infant. So I don't have time, I think, for the house surgeon to react, but still I will wait for 5 seconds. Quickly, few X-rays I will wait. You can unmute and answer or just post in the chat box. This is X-ray. Child is in cardiac failure. Oxygen started, bag mask ventilation, intubated, and then child was bed X-ray was taken. Bed X-ray gave the clue to manage the child, which is successfully resuscitated. This is bilateral pneumothorax. Bilateral is not easy to detect because unilateral pneumothorax, most of them are familiar. Are you able to see my cursor, Johnny? My pointers are seen? Hello?
Sir.
Seen, no?
Sir.
So this is the bilateral pneumothorax. So we were able to do insert the ICD now immediately. ICD inserted, air drained, intubated, bilateral pneumothorax. Child survived. From this happened in around 2000. Probably now ultrasound is there. Even earlier we can identify that. So bilateral pneumothorax drained, the credit goes to the chest X-ray. So how do you interpret the chest X-ray? There are very many ways of interpretation. I just classify them into very simple ways. General aspects, number 1. Number 2, chest wall and devices. Number 3, thorax, X-ray chest thorax. We'll compare the volume of hemothorax on both sides, lucency, cardiopulmonary angle, mediastinal shift in the X-ray of the thorax above the diaphragm, and then abdomen. In general aspect, these are the things we have to see. You have to check the name, number, date, time, and side mark. It's the AP or PA view, phase of respiration, any rotation. How is the exposure? We look at this as normal X-ray. Well exposed X-ray will have, you are able to see the vertebral spines as if we are viewing through the nylon cloth. They are just visible. They are not very clearly visible. This is a correct exposure. Correct exposure. This is an PA view. PA view or AP view depends on the comfort of the clients. Less than 5 years has to lie down, we'll take a PA view, AP view. Older child can stand, and then we'll take the AP view. PA view, sorry, I'm confusing. The lying down is AP view, standing up is PA view. In a PA view, usually you'll see the clavicle will be straight, and you can see the lung tissue above that. On the other hand, in the AP view, there will be notch in the clavicle. You won't see the lung tissue above that. Then look at whether is there any rotation or not. Rotation, how do you identify? Medial end of the clavicle on both sides. You just mark the medial end of the clavicle on both sides with the black arrow. The center point of the vertebrae, you make the white line. It should be equidistant on both sides. This is clearly visible here. If there is any rotation, the picture completely will change. So identify rotation, we can see like that. Next is, this is I told you, no, this is AP view where the clavicle appears like a notch in the middle. You don't see the lung tissue above. Here the PA view is straight clavicle and you will see the lung tissue above. But nowadays it's all electronic machines, no? Very easily. This is, you see the arrow, lying down posture. This is an upward arrow, standing posture. That itself will give the idea. We need not break our head. And then whether it is a properly inspiratory film. Now, ideal film is a deep inspiration film. Ideal film is properly inspiratory film. How do you know that properly inspiratory? The middle of the diaphragm should correspond to the anterior end of the fifth rib. Anterior end of the fifth rib. Then the next question is how do you identify the anterior and posterior ends? The anterior ends stop short of the vertebrae. They don't come and meet the vertebrae because this formed the cartilage. Cartilage is not visible. You see, this is the posterior end. Posterior end joins the vertebrae. So what is marked in the yellow number is the anterior end. White is the posterior end. So ideally, inspiration film should show the middle of the diaphragm should correspond to the fifth anterior end of the fifth rib. 1, 2, 3, 4, 5. So this is a properly taken inspiratory film. No rotation. Properly exposed, the vertebrae is visible. And ideally taken film is, this is ideally taken film. Side mark is on the right side. Name I have purposely masked because to remove the identity. So this is a normal quality X-ray film. Exposure, nowadays this problem will not arise because most of them are, the machines are, more advanced machines are there, exposure is correctly made. If you give more X-ray exposure, and this is the correct exposure, if you give less exposure, everything will like too white. And everything will be too dark if you give more X-ray exposures. So this is ideal. Overexposed film will be more darker, underexposed will be more whiter. But nowadays this doesn't happen because nowadays the X-rays are more advanced machines are there. So generally we may have doubt whether should I call this as upper lobe, middle lobe or lower lobe. To make it easier, this is a simple way. If I draw a line at the level of second rib, above that is the upper zone. Between 2 and 4th rib is the mid zone. Below 4th is the lower zone. This is very simple. So we need not break our head to see the upper lobe, middle lobe, lower lobe, because this is enough to convey the meaning for the other persons or the viewers. So this is a 4-step, I told you already, general aspect, chest wall and device, X-ray thorax above the diaphragm and below the diaphragm abdomen. We will see what are the chest abnormality we will see in the chest wall and device. You really will wonder, what are you going to do in the chest wall? But a lot of good things we can see in the chest wall. For example, and devices. These are the X-rays of 2 children who are just intubated, clearly intubated. Both the children saturation not maintained. It is done under laryngoscopic view of the glottis. Why I am showing this? ER and PICO almost part and parcel of the ward. Once child is intubated, we should know whether the tube is properly inserted or not. It's a very important observation in X-ray taken after intubation. I thought this will be useful for the house surgeon, postgraduate and young doctors. See here, the black arrow shows the endothelial tube. And here the whole left lung is collapsed. Only the right lung is open. Why the reason is, we see the right lung is almost, the endothelial tube has gone into the right lung. It's a right mainstem intubation. So left lung, no air goes inside, so completely collapsed. If we don't identify and rectify it, after half an hour or 1 hour, child will develop pneumothorax because the right lung will be inflated, left lung will collapse, child will end up in more complicated issues. So this is a deep endothelial tube. Here, this is the white arrow has shown the tip of the endothelial tube. This is the nasogastric tube. Ideally, tip of the endothelial tube should be midway between the clavicle and carina. I hope you are able to see that. Any doubts, you can just quickly ask. Unmute and ask if it is allowed. Are you able to follow me? This is the clavicle. What you can see the branching trachea. This is the carina, second white line. Ideally, it should be midway between the clavicle and carina. Tip of the tube should be midway between here. But here the tube is very high up. When you say what is the problem with the high up means, it won't give a proper ventilation. There will be a big leak will be there. This is also not correct. Even deeper also not correct. Higher also not correct. If you see the nasogastric tube, it is very superficial. If you feed the child, probably end up in aspiration. The ideal nasogastric tube should form a C curve in the stomach. So this is a deep tube. This is the too high tube. Both are not correct. So this is the ideal one. You can see that, no? This is a clavicle, carina. Ideal tip of the endothelial tube should be midway between the clavicle and carina. If you want to have a landmark in the vertebra, it should be opposite to that of the T2 or T3 vertebral body. You can see that, no? T1, T2, T3. It should be just opposite T2 or T3 vertebral body. That is the ideal insertion of the endothelial tube. Hope it is clear. So chest wall, what you are going to see? A lot of interesting things you are going to see. In a chest wall, first you see 4 bones: clavicle, scapula, upper under the humerus, and ribs. These are the soft tissues. I'll repeat: clavicle, scapula, anterior of the ribs, and then upper under the humerus. So it will be very interesting to see what are all the interesting points you are going to gather from the chest wall. It's quite interesting. This is 14 months old child, fever and breathlessness for 3 days. The child came into ER, had tachycardia, respiratory distress, hepatomegaly. Any quick answers? I can't see the chat box. If Nisha, you can see the chat box, you can just announce me with anybody post the answers. That Nisha or that Johnny can help me by looking at the chat box. It will be more interesting if they interact. This is a big heart, cardiomegaly, pulmonary congestion. These two will explain breathlessness, tachycardia, respiratory distress, and hepatomegaly because this is a cardiac failure. Cardiomegaly and the plethora of the lung feels cardiac failure. Why the child develop convulsions? Any idea? Any guess? Nisha, anybody posted answer in the chat box?
ARDS they have typed.
Possible. ARD is also correct. You can keep interacting with me, Nisha, so that we can go faster. So that all ARDS, pulmonary edema, all these are possible. But why the child develop convulsions? So any child
There
convulsion,
is spraying of the humerus.
fantastic, fantastic. Whose person? I appreciate his wonderful observation. Look at upper of the humerus.
Dr.
Pardon?
Shilpa.
Congratulations to the doctor who has posted rickets, because otherwise, if we don't identify rickets, I will never identify vitamin deficiency. I will never treat it. Child will not improve at all. See, look at upper humerus. There is a lot of fraying, cupping, fraying, widening of the physis. You can also see the anterior ends are widened. You see that? Are able to appreciate?
Yes,
I
that
just
is
request.
also typed.
Very good.
Nestle has typed. There is widening of the
Nesri. Okay, very
anterior.
good. Very good, Nesri. Good, Nesri. I just request all the viewers to watch this in a larger screen, either in the laptop or a computer. If you see in the phone, probably many may not be visible. Just my request, see in the larger screen. Okay. So now you want to know how does the normal upper humerus, this is a normal upper humerus. See how clearly it is well demarcated upper humerus. Here it is frayed. Here it is, you can see the cupping also there and widening of the face also there. All this indicated there is a picture of rickets there. You can also see the widening of the. So this child we confirmed by taking vitamin D. Calcium was very low. Vitamin D was low. 0.8 millimole. Normal ionized calcium is 1.2, 0.8. So it's hypocalcemia confirmed by the taking X-ray. So you can see the all classical feature rickets are seen. So if suppose if I have missed this, probably completely missing treating the child with the vitamin D. This child echo also is interesting. Echo did not show an anatomical defect like ASD or VSD. It shows only cardiomyopathy. Final diagnosis, vitamin D deficiency cardiomyopathy, and child completely recovered with just vitamin D alone and calcium alone, child recovered. So a good observation, I picked up the child, it helped the child to recover faster. So any child with convulsion, please look at the upper end of the humerus. The upper end of the humerus will holding the diagnosis for you. 2-year-old boy, there was an intervention, he developed breathlessness. So what do you see here? In general, usually nobody will look at the neck, but your neck has got a good interesting find. It's an intubated child, you can see the endothelial tube. What do you see in the neck? For sake of focusing and just concentrating. There's a vertical black translucency there in the neck, indicating of air collection between the fascia and the muscles. So you can see that this is subcutaneous emphysema. And again, if you see the X-ray on both sides compare, the right lung appears larger and darker. Hope you all of you agree with me. Larger and darker, very close observation, you can see the pneumothorax. This is continuous diaphragm sign called. I mean, normally, diaphragm will not continue crossing the vertebrae to others. It continuous diaphragm sign, lifting of the thymus, and then vertical translucence in the neck. All this indicate air leak, pneumothorax, subcutaneous emphysema, pneumomediastinal. Again, I'm just showing a normal. It's not a normal one, but normal neck. It's intubated child. You don't see any vertical translucence here, but you can see a lot of vertical translucence indicative of subcutaneous emphysema. You can see the pneumothorax. You can see the continuous diaphragm sign, lifting of the thymus. All indicate presence of air leak. This is a child with fever again seizures. Seen his examination normal. Anything? For convenience, I pointed with arrows. Quick. Okay, I know time is almost 24. So you can see that no, anterior are very nicely dilated. You can see the beading of the anterior of the ribs. You can see the upper end of humerus showing rickets. So this is a child with rickets and hypocalcemia causing seizures. So again, confirmed with X-ray, you can see the cupping, fraying, widening of the physis. This I'm showing 2-3 X-rays mainly for you to concentrate on the X-ray chest, because nobody looked at the upper end of the humerus. When you are given a space, try to identify maximum from that. That's the purpose of showing this. Here in this child, I given a normal X-ray. This is a normal, it's an abnormal X-ray. Any clues? Quick. Nisha, can you take more than 10 minutes more, I think, if you permit? So this is an abnormal X-ray, this is a normal X-ray. Any X-ray, you don't give interpretation unless they provide the clinical features. I'll show the child here. This is the child. This child has got hepatosplenomegaly, myelothysis anemia, and also having squint indicating this child got a defective vision. Now, do you have any clue here? It's a normal X-ray. What is the difference between these two? 15 seconds, I will come up with the answers. Again, look at the upper end of the humerus. No, it looks like complete, like made of a chalk. You don't see the cortex and medulla completely different. So normally, if you look at the clavicle also, in the clavicle, the white line in the periphery is the cortex. Inner gray area is the medulla. The corticomedullary differentiation very well made out in the ribs, clavicle, and upper end of the humerus. Here, no differentiation at all. Everything looks like as if it's made of a marble or a chalk. Diagnosis?
Osteopetrosis they have
Very
said.
good. Osteopetrosis. So that's a compression of the marrow, myelothysis anemia, compression in the optic and auditory foramina causing defective vision and hearing, and hepatosplenic because of extramedullary hematopoiesis. Now you can see the difference. And ribs will show dense lines as cortex and inner medulla of the dark. It is not seen here. Everything look completely white like a marble. No clear distinction between cortex and medulla. This is osteopetrosis. Okay, now this is an X-ray. Actually, it's a rotative film. The child came with respiratory symptoms, bronchiolitis or bronchopneumonia. But more than the X-ray rotation, of course, rotative film, they look like as if we have a mediastinal mass. So just forget about it. Anything else you notice? Lungs are not very bad, but a new child had tachypnea. Child was put on high flow nasal cannula oxygen therapy because an alternate diagnosis of bronchiolitis. Anything else you see? We don't see another 5 seconds. I will move the anything strikingly abnormal. Okay, I'll just move then. Now we can see all the yellow arrows pointing towards what is this? Quick. Beautiful patterned artifacts. No, initially we thought calcification. Calcification will not be so regular. Beautiful, regular, and it has got a pattern. So it is not a calcification, it's an artifact. Usually calcification will be irregular. Calcification, nobody is going to form a clear, nice lumen-like shadows. Do you agree with me? So all the 4 arrows showing artifact, because it's an artifact. So initially we are also a bit worried because calcification, but one more thing is the calcification is gone beyond the body. This you look like probably in the lung. This also may be in the lung, but this is here in the vertebrae. Another one is near the clavicle. So does not respect the anatomical border. That means it is an told artifact. But the calcification is seen only in the lung fields. Okay, now we want to see. Shall I move or any answers? So what we did was we called the radiology room and asked them to check the cassette. Sometimes cassette will have an artifact that will cast in the check. But they said our cassettes are completely different, correct only, because we had taken almost 20-30 X-rays, nothing showed a picture like this. Then we lifted the baby and checked in the bed. In the bed, there was a bead kept in the wrist of the child. This bead got broken when the child is put into the bed. What you see is the bead. Tamil is called as parsimony. Probably Malayalam also will agree to that. This parsimony is spilled all over the bed. That has created the artifact. Now you see what you see is the parsimony or artifact. If we don't identify the artifact, unnecessarily we were discussing whether to go for CT scan to identify the unnecessary child would have had exposure. So reasonable narrowing the diagnosis and checking the environment, we brought the diagnosis. Okay. This is an adolescent boy, severe pneumonia. You stayed in ICU for 3 weeks, intubated, HFNC. A lot of findings are there. And for the sake of convenience, I just put it in arrow. Look at the yellow arrow and black arrow. What do you see in the yellow arrow? This day 1 of admission, day 15 of admission. Look at it very carefully in the first yellow arrow, you can see a calcified shadow. But unless the shadow persisting in all the X-rays, only can call this calcified. Otherwise, maybe an artifact or maybe a vascular marking. You can see this. It is completely present in a day 1 admission X-ray, day 15 admission X-ray. You can see also another small spot, calcified spot, present both in X-rays. Anything else you see also in the soft tissue, in the axilla, you see irregular calcified. So you see a lot of calcium. Even here also, because I didn't want to put a lot of here, can you able to appreciate just about the right diaphragm, you see 2 calcified spots. Agreed? Here again, on the left lung also in the base, lot of calcification in this child. Almost more than 6-7 calcifications. Okay, this is a closer view. Same calcification even on day 20. Any guess? Calcification, and you see that it is not an artifact. Artifact will be beautifully made. Calcification is naturally made. It will be only irregular. A lot of calcifications are here. You see the calcification in the below diaphragm also. Any idea? Anything? Quick. Any answers, that Nisha? You can,
No.
Nisha, you can keep it open. You can unmute and unmute. So generally, calcification means a granulomatous lesion. So it can occur in tuberculosis, sarcoidosis, and then this is our diagnosis. See, all the X-rays I have just pointed here, black arrows, red arrow, everything. See, extensive calcification, both lung fields and axilla, turned out to be a chronic granulomatous disease, healed granulomatous lesions. See how beautifully the clue is given. But in the first X-ray itself, we notice a calcification, but we opt for NBT. NBT was negative. But later turned out to be DHR was positive. DHA is more specific for the chronic granulomatous disease. And genetic study also showed a chronic granulomatous disease. This again stresses the importance of simple X-ray chest. X-ray chest knew that it is a chronic granulomatous disease by providing lot of calcification and chronic lung disease and severe pneumonia. Do you agree with that? How the chest X-ray is so wise? Genetic test came after 8-10 weeks, but X-ray chest, an old man has identified this calcification. And now we didn't think strongly about CGT. We were thinking about tuberculosis only, but it was CGT. See, that's how the old man still remains, and he doesn't have any competition. This again, this is a child had multiple problems, and you can see that no lot of tubes are there. There are chest tubes inserted both sides. This is a chest tube. This is the hole, peripheral hole should be inside. The discontinuity in the radiopaque lumen is because of the presence of hole in the analytical tube. Sorry, chest tube. Here the hole is outside. If we don't correct it, it will absorb air from atmosphere. So it has to be removed at the inside. What else you see here? There's a needle here, and this central line goes into the heart. So it's an IV drip connection. So this is portacath or chemoport. This picture was almost 96. This is a very old one. Pepe, this is a chemoport. I will just show what is a chemoport. You can see the ICD tube, chemoport, IGV line. This is ICD, which is a peripheral hole is outside. So this is a chemoport or Hubert called a device, chemoport or portacath. So here, actually, this will be, I see most of you know, I don't want to explain, but still I'm just telling this. Silicon bulb is inserted below the subcutaneous, below the skin. So for all chronic disease, including malignancy, immune deficiency, the child comes in septic shock. Child, we may not get central line. So because of the presence of this, immediately, this is called Huber needle or grip needle. The needle will be something like our scalpel needle, only that it will be vertically placed. Horizontally placed like a normally it will be scalpel, it will be like this. Here it is bent at 90 degree. You just wear sterile glove, clean the area, and prick the device bulb. You're inside the central line. So within maybe 1 minute, you can secure the central line and resuscitate the child. So nowadays, most of the malignancy cases are inserted. Probably as house surgeon, you might have seen in a lot of adult patients. Children also they are being used. So this is another case, this child LCH. Now the chemoport is smaller, inserted on the side. This is chemoport, LCH. Okay, now quickly look at the ribs, 1, 2, 3, 4. First, second, third, fourth rib look little different. Fifth is all other differences are different here because it's a bifid rib. 1, 2, 3, 5, 6, 7 are normal. Only fourth is divided because of the bifid rib. Bifid rib is a congenital abnormality. It's not a very serious anomaly. Only that you must be able to identify, that's all. Here, what do you see? This is cervical rib. Rudimentary cervical rib. Again, this is not a serious problem. It's not going to cause any problem, but the child may, an adolescent girl may come with pain in the shoulders. We look at it very carefully. This is one of our professor taught us in the period of house agency. See, this is the C7 vertebrae will be showing hand up and laterally. So T1. T1 vertebrae, the transverse will go up and laterally. C7 will go down and laterally. I think it's very clearly visible here. This is C7, this is T1. The rib is attached to C7. So when you follow the rib, it attaches to C7. So that means a cervical rib. One more clue is the rudimentary rib. Normal rib will not be rudimentary. These two features suggest that we got a cervical rib, rudimentary rib arising from the attached to the C7 vertebra. So this is a cervical rib. This is a very, very obvious anomaly. Are able to make it up? I'll wait for 10 seconds. Nisha? One big bone is missing. Okay, what is missing is the clavicle. You see the clavicle here?
Absent clavicle.
Absent clavicle. See the absent clavicle. It's called cleidocranial dysostosis. A syndrome called cleidocranial dysostosis. This also will have a separation of the pubic symphysis. It's a cleidocranial dysostosis. The child came with a high fever, and then when I saw the child, it was again around 2000 when we were in ICH. The child had a chest wall swelling. When he touched it, as I felt that I was touching a tabletop. It was so hard, discolored. I didn't know how, I could not identify. Only my surgical colleagues said it's a necrotizing fasciitis. He compared the chest wall and both said this child's chest wall is swollen. It was looking hard like wood and also discolored. So it's been gangrenous of the chest wall because of the toxin induced. So the surgeon took the child right from ER into the ICU. Completely, all the necrotic tissues were removed to clear everything so that the child is saved. Usually, necrotizing fasciitis is a complication of chickenpox or any serious infections. Here again, the CT also showed the thickening of the chest wall. So, in short, chest X-ray does not require very brilliant brain like interpreting CTR, MRI, PET CT. It's only child's mind, curiosity, imagination, and some background knowledge. See how the child is looking at it. If you look at this, if you look like this child looking at the X-ray in the viewer for 2 minutes, you will make big diagnosis. So now coming to lungs. Coming from chest wall, move to lung. Lung, there are 4 aspects you have to compare. Compare the volume on both sides. Compare the color on both. Color means lucency. Look for mediastinal shift. Look for costophrenic angle. So this is the yellow, equal on both sides, a normal. And then 1/4 of the heart shadow will be on the right side. If it is more than that, is shift to right. If no heart shadow seen on the right side at all, it's a shift to left. Here the costophrenic angle is very sharp. So color or lucency equal on both sides. Volume is equal on both sides. Mediastinal shift means normally 1/4 of the heart is on the right side. If it is more, it is shifted to right. Less, it is shifted to left. And look at the costophrenic. These are the 4 things you have to see. So now I just for the sake convenience, I divided into white lungs and black lungs. More white shadow. Normal color of the heart is like a gray shadow. With the bronchosal marking, grayish lung with the bronchosal marking seen as a white branching shadow. That will be the normal appearance. If the lung appears more white, these are the differential diagnosis. Pneumonia, collapse, pleural failure, pulmonary edema, ARDS, foreign body, and tubercular fibrosis are rare in children. Viral pneumonia, there will be interstitial pattern will be so. So you'll be seeing peribronchial thickening, variable hyperinflation, and branching shadows will be there. Bacterial pneumonia will show large area of consolidation, air bronchogram, varying density. But in pleural fade, there will be uniform density will be there, no air bronchogram, mostly white, whole white thorax. CP angle is, cardiac angle is obliterated, there will be mediastinal shift to the opposite side. Volume of hemithorax will be normal or increased. If it's a collapse, the collapse is the only diagnosis where the density, white density with reduced lung volume. And mediastinal shift to the same side. We'll see that. This is viral pneumonia pattern. See here, lot of shadows on the right side, and cardiac borders are looking very dirty and fluffy. Within 24 hours, completely, all these are because of atelectasis, because of the airway inflammation causing atelectasis. So within 24 hours, you see completely they are changed. So this is classically picture of viral pneumonia. So generally, they stay in ICU for a shorter period. So if it is a viral encephalopathy, what are the reason? Viral encephalopathy means extensive pneumonia, pulmonary edema, and ARDS. So this child consumed kerosene, massive injection of kerosene, came to ICH ER, and then you can see the completely whitened out lung. ARDS. I just okay. So this is a massive aspiration leading to ARD. You don't see the heart shadow at all. If you don't see the heart shadow, ARDS. Now we can see ARDS like picture. Okay, this is a 80-year-old girl brought to emergency room at 2 a.m. with distress, sweating and cold limbs. Child was in cardiac failure, gasping, proximal pulse absent. History was sleeping child suddenly got up and cried. Took to a nearby PHC and then referred here. The child on arrival itself had ventricular tachycardia. When he tried to intubate child with ventricular fibrillation, could not resuscitate the child. What is the X-ray appearance? Quickly. Here you see simple bilateral opacities, symmetrical bilateral opacities, something like a bat wing appearance, bilateral opacities. Bat wing appearance happens in classical pulmonary edema. See here. Very good. No scorpions. You see, unfortunately, we could not save the child. See the clear-cut pink frothy secretion, so much of secretions in the lung because of it. Again, a bilateral pneumonia, bilateral opacities. You want to see the child with oral thrush, the child immune deficiency, and extensive bronchopneumonia. So here you see a child with increased lung volume, opacity, complete opacity on the right side. Okay, relatively, the lung volume is increased. Uniform density, no air bronchogram. CP angle is obliterated. It is more likely to be a pleural fluid, but confirmation can be done only by USG, CT, or needle thoracentesis, but more likely to be only pleural fluid. You can see that. This is a child with pneumonia where you can say varying density. This is empyema or pleural fluid. This is varying density. Costophreneal angle is intact. We very closely observe this yellow arrow points to an air bronchogram. So air bronchogram will be seen in white shadow in the presence of pneumonia or ARDS. Definition of air bronchogram is a branching black shadows in the background of the white lung. Branching black shadows indicate the presence of air in the bronchi. This is always seen only in pneumonia and ARDS. This will be absent in pleural. See here, you don't see the air bronchogram. So this is the classical difference between pneumonia and pleural fluid. But final diagnosis confirmed by ultrasound and needle thoracentesis or CT scan. So this is here you can see the air bronchogram. This is retrocardiac pneumonia. You see the cardiac borders are masked. Here the CT clearly shows there is a consolidation with the air bronchogram in the left lower lobe. Here you can see the necrotic pneumonia. This is called a silhouette sign. Sometimes the pneumonia will be identified by the masking of the cardiac border, mask of the diaphragm. Here you see the left middle, left lower lobe pneumonia, masking of the cardiac border. So this is a child, 12 months old child with cough and respiratory distress, treated for 2 weeks in Gulf. The child had cough, but the shadow did not disappear at all. But one thing, you don't describe shadow alone. How was the child? Child is well child. No fever, no respiratory distress, but had only cough. Then they decided to come to their motherland, India, and the diagnosis confirmed. What is the diagnosis?
Thymus.
Very good, exactly thymus. Any child less than 18 months, asymptomatic child, if you see a shadow on the right upper zone, it is more likely to be thymus, the classical side-like appearance, thymic shadow. This is a child present biphasic stridor. Normally, stridor is the inspiratory stridor. Biphasic stridor means it's an intrathoracic upper airway obstruction. Obstruction is there between the glottis and carina. Intrathoracic upper airway obstruction. So biphasic stridor. You can look at this, clearly you can see somewhere enlarged shadow is seen, indicating a mediastinal node turned out to be a child with lymphoma. Are able to appreciate this side is not on left side. Right side clearly you can see mediastinal node lymphoma, mediastinal mass lymphoma. This we have already seen. I just skipped this. Okay, here you see the lung volume. There's opacity on the left side. Definitely opacity on the left side, which may be pneumonia or pleural fluid or atelectasis or a mass lesion. But look at the lung volume. Lung volume on the right side is normal. On the side of opacity is normal or reduced. Same line only I put it. Hello?
Reduced.
Definitely reduced. You can also see the concavity crowding up. So the diagnosis here is pneumonia or ARDS, a pleural fluid. What is the diagnosis? Atelectasis. Reduced lung volume and white opacity, crowding of the ribs means atelectasis. Same child I'm showing there. This is a very interesting story. This child bronchiolitis, intubated, child developed left lung collapse, after good physiotherapy and suction. Third day, lung atelectasis expanded. Any shadow, when you think of atelectasis, whenever there is a reduced lung volume, crowding of the ribs, or quick appearance, quick disappearance, this is in favor of atelectasis. So by third day, completely whole shadow disappeared. The same disappearance we won't expect in pneumonia or pleural fluid because the physiotherapy expanded. On fifth day, what happened? The collapse is gone on the right side. So this is called shifting collapse. This usually happen in a child with foreign body, migrating foreign body, a thick mucus plug, or a child with weak cough reflex. This is turned out to be a child with spinal muscular atrophy, presenting with bronchiolitis and collapse at the age of 6 months. So here, this is the any shadow with the concavity, outside well-defined shadow, concavity facing lateral side is atelectasis, right upper lobe atelectasis. Here, if you can see lower lobe atelectasis, right lower lobe, left lower lobe atelectasis. Segmental opacities are seen, triangular opacities with concavity facing outside, dense or well-demarcated areas are called segmental collapse. Here again, this is a child has been in ICU for a long time. The child has got tracheostomy tube, gastrostomy tube. This child with neurologic problem. The whole left lung is collapsed. Why you say collapse? Because there's a mediastinal shift. You don't see the heart pattern at all on the right side. In addition, there is a segmental collapse on the right side. This is the VP shunt. So after good physiotherapy, after 48 hours, the collapse expanded. You see that segmental collapse persists. This is the gastrostomy tube. This is the analytical tube. So this is atelectasis, which appears and disappears very fast. Now, it's a pleural fluid. This pleural fluid, child with empyema. How do you differentiate whether it's empyema or pleural effusion from the X-ray? X-ray cannot tell the differentiation at all. It's only the associated clinical find. If you see a child with febrile, toxic, sick-looking child, young child, that is empyema, dyspneic, grunting. If the child is comfortable, completely comfortable, it is a surprise for you to see the X-ray in the effusion, then it is pleural effusion like tuberculosis. So this is empyema, child underwent VATS. You can see the ICD here. This is a child with dengue. You see that 9th October, 12th October, 14th October, 15th September, 9, 11, 12, 14, and 16. See, pleural fluid increased, massive, and almost 7 days it spontaneously got absorbed. Does not need any fluorocentesis or thoracentesis to remove the fluid. In dengue, automatically body absorbs. This is a 3-year-old child with fever, breathlessness, 2 weeks, dullness and absent breath sounds. Right hemithorax, complete opacity. A minimal, normal or slightly increased lung volumes, no air bronchogram, cost of lung angle is obliterated. What is the diagnosis? These are the list: pneumonia, collapse, pleural fluid, pulmonary edema, ARDS. So this is an IC tube is there. So what is it? Any answers in the?
Fluid.
Yes, probably pleural fluid, but why the end of the intercostal tube has not drained that pleural fluid? Because any amount of any big tube also cannot drain a solid mass. This is we went for CT, see the tube is entering into the all mass. This is a neuroblastoma. So neuroblastoma. But I just showing the CT picture. Normally, in a pleural fluid will form a crescentic shadow. Here it is a mass lesion, neuroblastoma. 2 years old neonate, and mediastinal shadow is there. Initially, we thought cardiomegaly. Echo was normal. We subject to CT chest. What are looking uniform shadow in the CT showing a multiloculated cyst with a different density with calcification turned out to be teratoma. So after surgery, the mass is gone. This is interesting stories of 3 coin shadows, A, B, and C. This is a coin shadow. The child came with shadow on the, these are all ICH pictures. Came with a foreign body. There is a round shadow. Round shadow means in the neck means it is probably in the cricopharynx. If it is in the coronal plane, if it is sagittal plane, if it is indicative of the foreign body is the trachea. This is a cricopharynx. So lateral we showed a clear coin. Call the ENT surgeon. In the ER itself, we removed and child was not admitted and sent back home. That is coin A. So this is a 2-year-old child, Down syndrome, brought a drooling of saliva. It happened in year 2000 because we miserably failed in diagnosing this child. We lost the child because in 2000 we never had an idea that this will be a diagnosis. So again, coin in the cricopharynx. Around child came around 9:30 in the ICGR. Called the ENT surgeon tried to remove. It was difficult to remove. Then he said the child saturation is normal. So we told we'll remove as a first case that morning at 8 o'clock. So he went back. Foreign body. Then morning 8 o'clock, they removed the foreign body and child developed air leaks. This X-ray you saw of the air leak, pneumothorax, mediastinal, and the air leak syndrome. Why I asked the surgeon was difficult to remove. That's why the trauma is second. He said very easy to remove. And then child also developed bilateral pneumothorax. When he removed the foreign body and cleaned only, we realized that it's not a coin, it's a button battery. In year 2000, we never had idea about button battery. And probably now we can make it out. So this is button battery. Last again a coin shadow. So any coin shadow, think about button battery, try to remove as early as possible. And second, this thing is always taken lateral view of the child, lateral view of the X-ray. So what is the lateral we showed? Surprisingly, it showed a car wheel. It's a car wheel. I don't know how this bellows swallowed it, penetrated the trachea, leading to perforation and air leak syndrome came, and there's a lot of difficulty removed. So any coin shadow on the neck, always presume as foreign body and take a lateral view to identify any other possibilities. This miliary tuberculosis, clearly uniform density, millet-like density distribute all over the lung fields, miliary tuberculosis. Nowadays, it's better seen in the CT than X-ray. See, CT look like a picture drawn. So this is miliary tuberculosis. This is Nisha. I have only 10 more minutes. How much time I can take so that I can sip some X-rays? Can you just tell me? In the meantime, I'll discuss with Johnny and let me know. Here, if you compare the lung fields, the left lung is completely darker and larger. So the air collection here. This is here, the right lung is smaller, mediastinal shift there. Classical history of foreign body airway. So here is hyperaortic left hemithorax, mediastinal shift. Bronchosal markings are very less. It's an obstructive emphysema because of the foreign body. This is different pneumothorax. Here, completely dark lung. Here the lung is not so dark. So this is on left side dark lung. See the collapsed lung. And you can also see the diaphragm is flattened. This is diaphragm round. The flattened diaphragm, collapsed lung, completely dark pleural this is indicated pneumothorax. It's a pneumothorax. I put all this in the same picture. This pneumothorax, obstructive emphysema. There's another entity called granulomatous emphysema where collapse of the left lower lobe. This is for comparison. Nisha, what did you say? I didn't listen. After draining air, lung has expanded. Nisha, can I take another 50 minutes time? This is lung cyst.
Yes, sir. Yes, sir.
Lung cyst. So lung cyst in X-ray. If it is surrounded by a consolidated lung, it is called pneumatocyst. Normal lung means lung cyst, thin wall. CT proved. And this is air leak in a child with asthma. Always any child coming with severe asthma, completely palpate the neck and the chest wall. You will identify air leaks. There is an air leak, the child definitely need an ICU admission. You can see the subcutaneous emphysema here, the chest wall, pneumomediastinum sign, but fortunately there was no pneumothorax. This is Kundal Panay, a beautiful plant. So far we are seeing only black and white shadow. You can see a color shadows. This is neonatal cyanosis. You don't see the diaphragm here on the left side. This is diaphragmatic hernia in newborn. This child had a CP, microcephaly, global development delay. Child was brought to the respiratory distress, intubated, ventilated for 2 weeks. It happened when he was working in Gulf. We ventilated the child for 2 weeks, recovered and discharged the child. Child came after 2 weeks with severe respiratory distress. This time we saw a new shadow. Any guess? Initially, I thought pneumothorax or this thing, but nothing. Pneumothorax will be on lateral side. Pneumopericardium again will be in the center. You won't see any vascular markings. So any guess? So finally we come to this suspicious gas shadow.
Eventration they heard.
Eventration will be seen only in diaphragm. You have come very close to there is a large bowel shadow. So whenever it is suspicious air shadow, think about surgical problem also. We did very minima. You see the Morgani hernia. I'll just go back to the previous degree. What you're seeing is a hostation of the large bowel. So this is, you can see the Morgani hernia. This child, 2 months old child, came with cough. Because of mild tachypnea, we took the X-ray. X-ray showed a suspicious gas shadow here. When I first time saw, I thought it's a fracture of the ribs, but it's seen both sides also. It's a suspicious gas shadow. Lateral we clearly differentiated a sliding hernia here. The medium swallow showed the sliding hernia. After surgery, the shadow disappeared. Heart shadow, cardiomegaly. Here, this cardiomegaly is little different from the other cardiomegaly. Here, it is a lifted up shadow right on the apex, cyanotic heart disease, phallostetrology. The child came with cervical adenitis in OP and then developed abscess, incised, then came with fever, respiratory distress. X-ray showed empyema. We drained the pus, but still the child did not improve. And then we thought something wrong with the heart also in call, but this is again 2000 and 2001. We didn't have the focus or ultrasound in our ICU at that time. So we called echo and found out to be this is the diagnosis. Any diagnosis for this cardiomegaly, but not improving. On the left side, empyema, it got improved. Any guess? This cardiac study little different. Pardon?
Pericardial effusion.
Exactly, correct. Now, how do you say pericardium? This cardiomegaly, you see, this cardiomegaly got retained in the shape. Shape of the heart is there. Shape is last here. Second is this cardiophrenic angle is sharper here. Here it is obtuse. And then very important finding is most of the cardiomegaly will have a plenty of vascular markings with the plethora will be there. Here complete pulmonary oligement because the pericardial effusion does not allow diastolic filling. So now it's pericardial, pyopericardium. You see that. See, in other cardiac failure, a lot of lung fields will be there, plethora will be there. Here it is oligemia. This is a pyopericardium. But nowadays it will be picked up earlier by ultrasound focus. This is a child with a pneumopericardium. You can see the heart shadow pneumopericardium. The cardiomegaly, instinctive cardiomegaly turned out to be a mediastinal mass after surgery. You can see that. Below diaphragm, what you can see is the normal appearance, right and left diaphragm. Here it is. What is this? This already Nisha told the diagnosis. Someone told the diagnosis. What is he here? Left diaphragm at a higher level. Normally right to be a higher level. This is the eventration of diaphragm. So clue for eventration is always stomach bubble always follow the diaphragm. So left is stomach bubble. It's an eventration diaphragm. This right side eventration. Left side eventration needs immediate correction. Otherwise, they will be leading to torsion of the actually rotation of the stomach, malrotation leading to gangrene of the stomach. So surgeons immediately operate on the left side of the eventration, right side of the vein. So this is below the diaphragm, abdomen. Cell intestinal obstruction, distension. We see the pile of coins appearance. It is due to obstruction at the level of jejunum ileum. So what you see the dilated jejunal bowel, you can see a nice coin-like appearance. While so if it's a characteristic like characterless dilated bowel means it's ileum. Ileal dilatation, jejunal dilatation. Okay. What you see is a child with having multiple opacities are there. Can occur in a lot of things, lead poisoning, iron trichloral poisoning will be there, meconium peritonitis will be there. In some part of our state, they used to administer mercury for a newborn baby. There also we can see radiopac capacities. But commonly the shadows reflect the iron tablets. This is multiple magnet injection forming a garland. The multiple magnet injection stuck to the bubble and lead to intestinal obstruction and gangrene. I'll just skip this also. Now quickly I can see some T's. This is a tuberculosis, gone focus. It is seen better in the gone focus. It's a beautifully our radiologist professors that they used to say Elizabeth John used to show a lot of interesting X-rays on tuberculosis. It's a gone focus, white one. It is seen better in the CT picture. It's a gone focus. It's a node. You can also see in the lateral view. This is the tuberculosis focus. This is sometimes source of where are you coming from? This address makes a diagnosis. Maybe I can just wait for 5 seconds for you. 3-year-old child, acute onset, low-grade fever, chest pain, hypoxia, disproportionately severe tachypnea and distress, hypoxia, very sick child, pale. He's got an underlyingness. Mother could not say his problem, but he says this boy has got a problem there. Some underlying illness is there. So then we asked the address. Address gave you the clue for diagnosis. Any guess for that?
Sickle cell crisis.
Fantastic. Sickle cell crisis. Fantastic. So he is from Tamil Nadu. We don't see a lot of sickle. Maybe in Ooty, hill stations we see. But it's child from MP, Gujarat, Orissa. It's sickle crisis. In Nilgiri Hills in Tamil Nadu, sickle is seen. So if you see a pneumonia-like picture, and very sick child, you think of sickle cell disease, sickle chest. We have to do X-ray transfusion. So I just skipped the trauma X-rays. I'll just show that. It'll be interesting. So whenever you see because I think Nisha and Johnny has given me another 15 minutes, I can go little slowly. So whenever you see a picture like this in a normal setting, it's pneumonia. If you see a pneumonia-like picture in a child with polytrauma, that is contusion of the lung. This look like eventration. Whenever you look like an eventration diaphragm in a child with polytrauma, it's rupture of diaphragm. Whenever you see a cardiomegaly in a child following trauma, it is hemopericardium. So we learn from known to unknown only. I know pneumonia. That's why pneumonia-like picture in trauma is contusion. Eventration-like picture in a child trauma is rupture of diaphragm. Cardiomegaly in a child following trauma is hemopericardium. So where is a hidden trigger? See, looking at X-ray is only your focus. How nicely concentrated focus. How your eyes are focused on some diagnosis. Where is a hidden tiger? Where is a hidden tiger? Any answers? I see only one tiger. Where is a hidden tiger? It's a power of inspection. Good X-ray film, good eyes, good power of inspection can identify a lot of important abnormalities in the X-ray chest. See, this is the picture taken by one wildlife photographer. He's also an artist. He very nicely written as hidden tiger in the. Look like the stripes of the tiger, but he's very nicely written HADDEN. That is a hidden tiger. They showed. Okay. This is again a very important picture. I took it from Nelson because this was very beautifully given there. Very common nowadays, increasing, incidents are increasing. We are not supposed to miss. This child came with multiple problems. Child came with a discordant family setting and mother was not available with us. Someone child brought it. The child was crying all the time. When you look at it, I'll just come to the point directly. The child had all the signs of child abuse or non-axial injury, the cigarette butt injury, patterned pinching, belch injuries, all that. We concentrate on the two types of injuries are there. They all shown by black shadow is old shadow. Do you think it's old fracture or new fracture? Black arrows. No, what's spending time on this X-ray? Any guess? Black. What is the difference between the black arrow and white arrow?
Old one.
Older because callus is there. So this child is developing fracture at different timings. This can happen only in two situations. It's a child abuse or osteogenesis imperfecta. So here, the fracture is completely new. No callus formation. Probably it would happen in 2-3 days time. This would happen some few months back. We see multiple. It also shows hemothorax here. All is pointing towards a child abuse or non-axial injury. So this X-ray, we should be very. Nowadays, earlier we used to take X-ray and see. Now the CT seems to be a better modality to identify. Whenever a child suspect child abuse, better don't make a decision only on X-ray chest. X-ray chest is still an old man. His eyes are not that good like a young man like CT. So go for CT. This child, when the child came to us, he came to the late evening and night. My PG sent this X-ray. After seeing the large one, I thought it may be maybe a hernia. When then looking at it, turned out to be a child with CT and all proved that it's a large cavity. Mother was sputum positive, AFE positive, not irregularly in treatment. The child infant, see large cystic, 4-5 months only, large cavity. You can very closely observe the miliary mottling. So the child died, Mediastinal mass. This is a normal thyroid appearance of the CT. So this is a child, you can see the gradually 3 months old child came with fever, cough, and respiratory. This is what's your diagnosis here. Round pneumonia. Round pneumonia usually happens in pneumococcus, staph aureus, and tuberculosis. Very short history, 3 months old child. Then, if you look at it very carefully after a few days, you can see a little dark area inside. This may indicate a resolution or worsening and necrotic pneumonia. The child continuously had fever and respiratory distress. Is worsening. Can you appreciate? This is a necrotic pneumonia. Same time, child also had a swelling of the ring finger showing the features osteomyelitis. And one fine day, child coughed out a blood stain sputum. Now we can see the cavity. So round pneumonia, lung abscess cavity, blood culture has grown MSSA, methylation central staph aureus. Child completely recovered following anti-staphylococcal treatment. Round pneumonia, osteomyelitis, disseminated MSSA, methicillin sensitive staph aureus. The child was sleeping in one of the busy market area in Chennai. A jeep came backward and run over him, partial run over. It's a tire markings, hemothorax. This is scoliosis, lung abscess, proved by the CT also. Scoliosis, lung abscess. This is a child with mediastinal shadow. See, the yellow one is a normal shadow. Red is widened mediastinum, pleural fluid. Turned out to be child with CT showing pictures of lymphoma, pleural fluid. This I can go a little slowly. The child came to us evening around 4:35 o'clock to ICH Pickle. History was the father, the uncle was, you said, myself and my niece were going in the cycle, and she was going in a cycle, a water lorry came. So we were very carefully avoiding the lorry. We came to the edge of the road and we fell down. And I asked him straight question. Then immediately went to a nearby medical college. The child had multiple problems. The X-ray, I'll show the X-ray later. So they thought it's a polytrauma victim. Put in the spine board very sincerely, immobilized the chest and spine, and came to us. See, spine board, everything is there. This is X-ray. You get a lot of findings. Maybe 5 findings are there when you just look at the X-rays. Can you at least few you can say? Unmute and say we're coming to the end. You see the chest wall, no? Chest wall, there is completely
Air and diaphragm.
air and diaphragm,
Against
and then
emphysema.
subcutaneous emphysema, lifting of the thymus. Fortunately, no pneumothorax. You can also not only that, see the perinephric kidneys are air collection around the kidney. But child was looking good only. So any pneumothorax following a trauma, most likely due to fracture ribs causing laceration. And I asked him, but the child does not have any pain. And the child was looking good. The saturation was 98, 99. And then we took CT to remove spine injury. And then we removed everything and told the resident that if the child maintains saturation, don't do anything. If the child develop desaturation, take an X-ray, look for pneumothorax and insert the ICD. That was history. And again he asked, then did you hit by a lorry? He said, I don't hit by a lorry, but I just, when avoiding lorry, I came to the edge and we fell down. When he fell down, she started crying. Cycle tube also pricked her. She cried and immediately she bloated. The history he was telling in fast speed. I could not connect all the history together. Suddenly she bloated. My unfortunate thing is cycle valve tube also broken, but I avoided the lorry. Something like I was telling, but I could not connect everything together. But when I think over only, I could come to the conclusion. Here you can see a lot of air leak, where the air came from. Sarcoidemia, neck, chest, pneumoperitoneum, perinephric pad. So because we took the CT mainly to see the vertebral or rib injury, then radiologist called and said that there is a small air bubble in the intraspinal cavity also. Are able to see small bubble. See, yeah, now we'll trace the air where it came from. See, left heel you see the air shadow, right heel it is not there. Left leg is also air shadow is there. Left thigh. So it preferred only left. Very sincere road rule following citizen. The air followed only on left side it went. And went up to this. You can see the air collecting in the front of chest. See, this is the child appearance, bloated face. This is the injury. Here, you can see the prominent chest because of the subcutaneous emphysema in the chest. Then we could identify that what happened was he did not have any fracture rib to cause laceration. Cycle tube punctured the heel and then broken, and the whole cycle tube, 200 to 300 ml of air in the cycle tube is emptied into the body, emptied into here, and then traveled from heel to leg to thigh into abdomen, chest, everywhere. Then I think only the anatomy professor could explain how it traveled all over the body. Then now you have to believe me. The same child after 1 week and the cyclone got resolved. After 1 week we gave only option. We didn't do anything big. So only way to believe me is see the color of the dress, same color, same child because of emphysema. This is a normal face of the child. So cycle tube. So the lesson I learned from this history is the case scenario is always believe the history given by the parent or the attendant. They are correct because I could not connect all the points. I cannot tell him that he's not giving correct history. Always believe the patient, believe the parent, believe the family members. So coming to the last slide, he is Ranjan. discovered in 8th November 1895. One of the greatest discoveries, something I used to compare this with ORS. Small technology has given a lot of scope for us to make big diagnosis, like upset emphysema, bronchogenesis, mediastinal mass, lymphoma, everything. He was basically a physicist. So when he was working in the lab, in the middle of the night, no, most of them worked in the night only. Suddenly he saw some flashing lights, but he could not identify where is the source. Next time, it also caused some impact on his cupboard, metal cupboard. The next time it came, he called his wife to show the hand across. So his wife showed the hand across. This I believe to be the wedding ring. So this is the first X-ray made incidentally over a metal plate, 8th November 1895. So he's a great person. So he did not identify this as a ray, so he labeled as X-ray. Then people started understanding. Then they're surprised to see the bones and everything visible. Then people start understanding the importance of X-ray, and then started calling us Ranjan rays. So, but he politely, is such a humble person. He politely refused. No, don't include my name. It will be X-rays. Definitely, if I have discovered, I will not. I will say as Velu X-rays, or Nisha X-rays, or Johnny X-rays, or Riaz X-rays. He will not be the right, but he's such a humble person. He left his name and still called us X-rays. So, dear friends, sharpen your X-ray reading ability. Spend at least 2 to 3 minutes in front of the X-ray. Never see the X-ray in front of the tube light. Never see the X-ray for 10 seconds, 15 seconds, 20 seconds. X-ray has got such an amount of treasure. Sharpen your X-ray reading ability. At least 2 minutes you spend in front of the X-ray lobby to study this 125-year-old ancestral property like Ravi Verma's pictures, drawings. So to conclude, what are steps in chest X-ray interpretation? Because this I prepared for emergency room and ICU. Initially I labeled as 4 steps. Look at the tubes. Tubes may be analytical tube, BP shunt or chest tubes or lines, IJV line, subclavian lines, thoracic structures, abdomen. The assessment of the lungs, look at the volume on both sides, color on both sides, cardiophrenic angle and shift, cardiophrenic angle and whether in mediastinal shift. Two important aspects of the heart is cardiomegaly and pulmonary vascularity. Very serious signs in the chest X-ray we are not supposed to miss is highly placed tube, deeply placed tube, collapse, and pneumothorax. We never miss. So that's why the 2 minutes time you have to take. If you see finish within 15 seconds, look at it again, see is there any change in the tube side? Tube has gone deeper or superficial, is there pneumothorax, is there any collapse? Identifying them will be a great asset and great chance of saving the child. See, I have shared, no, in our days, we didn't get permission to show these X-rays and pictures from the poor children. So collectively, I thank them for those who shared their sufferings and visuals for the benefit of medical knowledge, which will save many more lives. I thank the family members and children who shared their visuals to me to discuss with you all. This is a teamwork in ICH Chennai. Myself, at the time I had good amount of hair. You have to believe me, this is me. My friend Dr. Ramchandran, Dr. Shanti, most of you may know this, Dr. Kulanai Kasturi and Dr. Indumadi, pioneer in pediatric emergency medicine. Thank you very much for your patient listening.
Thank you, sir, for that excellent and exhaustive session on chest X-rays. You have covered everything from exterior to the interior of the chest
Yes,
X-rays.
good evening, yes.
And also made it interesting with
Good
many
evening,
case
sir.
studies. So now our president, Dr. Riaz sir, has joined. I invite him for saying a few words.
Yes, a good old friend. He is not old, but he is our friendship is for a long time.
Actually, sir, I still remember my days of getting instructor training for parts from you and your team. So, always, your class is always special, sir. I think you have shared a treasure of information to us. I was not able to attend it fully. I was in another meeting, but at least half of it I could hear. And I think Johnny can share the YouTube link in the group. It
Sure.
will be useful not only to the house surgeons, but for all the pediatricians working in primary, secondary, and tertiary care all over the state. Thank you, sir. Thank you very much.
Thank you.
And,
Thank you for extending your time for another 50 minutes.
Thank you.
Thanks a lot. Thank you.
Okay, sir. Thank you.
Riaz was on our side. He was an ER and PICO earlier days. Now he became an endocrinologist.
Yes, sir. Yes, sir.
Shifted
Actually, sir, I started with ER and then ended up as in
into endocrinology.
endocrinology.
But both starts with E only. So you are not cross the border.
Yes, sir.
E
Yes.
only. Endocrinology or emergency.
Yes,
Thank you
sir.
very much. Bye. Thanks a lot.
Thank you. Thank you. Sir. Thank you
Bye.
very much. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, Johnny. Thank you, Dr.
Thank
Shah.
you, Thangavelu, sir, for that very elaborate talk and interpretation of chest X-ray that you explaining in a very, very simple manner. Even though it's quite late, we had a full house today, and many of the people couldn't join. So we had a very good session, and thank you so much, sir. And especially the point that we should see the X-ray for at least 2 minutes time. That is a very important take-home message for all of us, because many of us in the casualty as well as our BC OPD practice, we just give a glance and then we just come to conclusions. So it's very important. Thank you
All
so much,
older
sir.
people need some
If
time.
anybody
No?
has
All older
yeah,
people
no,
like
no,
need some
everybody
time.
could take sir. And basic points like CP angle, everything lines, everything has to be done in the systematic manner actually, because chest X-rays can give us a lot of clues actually. If any one of us have any questions,
Any
queries,
questions,
please
doubts,
unmute
I'm
and
happy to answer.
you can unmute and you can just ask. Any questions in the chat box? Everybody has only appreciations in the chat box for your sessions. So if there are no more queries, Nisha, can you please say the vote of thanks?
So, on behalf of IAP Kerala and the TIPS Presidential Action Plan, I thank Dr. Thangavelu sir for having an excellent session today. And also I thank the organizers and also for the house surgeons and all the practicing pediatricians and faculty who joined us today. Thank you.
Thank
Thank you, sir.
you
Good
very
night.
much.
Thank
Good
you,
night, sir.
sir. Good night.
Good night.
Good night.
Thanks a lot.
Sir.
Good night.
Thanks a lot for your patient listening.
Good night, Nisha.
you.
Good night. Thank you, sir.
Good night. Thank you.
Okay. Thank you, Johnny and Nisha.
Yeah, thank you. Thank you, sir.